So actually, I'll be speaking more specific about the UCLA series, particularly looking at the comparison of 3D conformal techniques and comparing those patients and how they did compared to the patient who recently had tomotherapy. A lot of stuff I think people have gone through, and in the interest of time, I can go through them pretty fast. I have no disclosures. Talk about role of adjuvant radiotherapy, briefly the types of adjuvant radiotherapy that we have offered in our institution, and then finally outcome based on the technique of treatment. As everybody has said, mesothelioma is a local disease, and it first involves in hemithorax, and microscopic disease is always left behind, and there is a role for adjuvant therapy to reduce postoperative local recurrence in the surgical bed. However, despite the fact that mesothelioma cells are sensitive to radiotherapy, clinical outcome has so far been disappointing. And that's due to the things that people have outlined, including the size of the area that needs to be treated and toxicity, the intrinsic radiosensitivity of normal tissue, including the lung, heart, esophagus, and the late effects of radiotherapy, including lung fibrosis and scar tissue in general. Finally, appropriately targeting these areas with sufficient dose to kill microscopic disease and preserve normal tissue function is the main challenge. So briefly, data on the role of adjuvant therapy after prolactin decortication. Many people have cited the study from Memorial Sloan Kettering, where they use hemithorax radiotherapy after prolactin decortication in mesothelioma. And bottom line is that this was done with traditional techniques, and authors concluded that radiotherapy was ineffective after EPP due to the poor local control and dismal overall survival comparing to the patients that got EPP and radiotherapy. However, they subsequently updated their study by looking at using the role of IMRT in patients who had malignant pleural mesothelioma, a smaller study of which 20 patients had pleurectomy decortication. All of them received adjuvant or radiotherapy with IMRT, which is a technique to carve out the areas to treat while minimizing dose to normal tissue. And in this cohort, median survival was improved prior to their other series, and toxicity was considered to be acceptable. Other people, including a group in Italy, have looked at tomotherapy in the context of delivering radiotherapy in the patient of intact lung. Their first study was strictly feasibility, looking at 28 patients with median follow-up 19 months, showing that only 7% had grade 3 or higher pneumonitis, and the authors concluded that radiotherapy, using tomotherapy, can be delivered safely in this context. They subsequently updated their study by looking at outcome in these same patients, where they deliver 50 gray in 25 fractions with a boosted gross disease to 60 gray. And the 2-year, 3-year progression-free survival were 65% and 46%, mostly what they consider out-of-field failures. There were no fatal toxicity, and 5 out of 28 patients had grade 2 to 3 pneumonitis. Again, they showed that local regional control was excellent with tomotherapy in the setting of intact lung after pleurectomy decortication. At UCLA, this is kind of a general paradigm where we consider patients with primarily epithelial tumors undergo surgery first, followed by adjuvant radiotherapy, and we reserve the chemotherapy only in the setting of recurrent or metastatic disease. In the setting with patients with sarcomatoid or biphasic histology, most patients will get neoadjuvant chemotherapy. That's the preferred route, followed by pleurectomy decortication, followed by adjuvant radiotherapy. In some situations where they have had surgery, it's our preference to give chemotherapy due to their high risk for distant metastasis, even though the radiotherapy will be given suboptimally in a delayed fashion. Moving on to the techniques of radiotherapy, which has evolved at our institution over the last decade or so. But the goal is the same, is to cover the prior pleural pericardial surfaces, tumor bed, lymph nodes, chest wall, diaphragm, surgical scar, port sites, and with the important goal of sparing the intact lung, heart, esophagus, etc., bowel, kidneys. Traditionally, as people have mentioned, the techniques is using photons, using APPA or anterior posterior parallel probes beams with lung blocking to shield the ipsilateral lung, other blocks to shield the spinal cord and the liver, and then using electron beam to boost those sites. And so this is a patient treated in this fashion. At the time of simulation, patients are, the surgical scars are wired so that we can visualize them on the CT scans and then appropriately boost these areas. And these are some of the fields using this sort of traditional 3D conformal technique, using lung shields and diaphragmatic shields. Liver blocks. So this is what it looks like on sort of the dose wash, which the color depicts the dose. And you can see the lung is being shielded with a lung block, but also shielding the sort of anterior chest wall, anterior pleura surfaces. This is sort of boosted with this electron beam. However, it's never a perfect match. It's often underdoses and overdoses certain areas, and it's really not a very sophisticated and elegant technique. Similarly, with the sort of this subdiaphragmatic boost to boost that area, it's to shield the liver, we have the same issues with coverage of the intended target. And so in summary, this is sort of what a 3D technique would look like, with the red outline is what we want to cover. However, it's sort of underdosing up to 50% of our intended surgical bed. As Dr. Chen mentioned, helical tomotherapy is a type of intensity modulated radiotherapy delivered with a machine that looks like a CT scanner, and the radiation delivered helically or slice by slice. I have a movie here, wish I can fast forward, but the second ladder shows sort of a helical delivery technique using this machine. And the benefits are that there is no field size limitation, because often the fields of these are relatively long and require matching of fields using standard LINAC-based radiotherapy. It's able to target sort of a rind much better because of the tangential way the beams deliver in this manner. And it's known to be able to deliver homogeneous dose to the intended target. Sorry, wrong direction here. So we sought to compare 3D technique versus IMRT and tomotherapy-based IMRT for a couple reasons. Primarily the fact that tomotherapy plans are more labor-intensive, they're more costly. Insurance company will always challenge us as far as the necessity of tomotherapy, and there's very little evidence showing that there is a clinical benefit. So we want to look at sort of, is there a dosimetric benefit, and more importantly, is there a clinical benefit in terms of tumor control and toxicity when comparing patients that were treated in these two different techniques. So from 2006 to 2012, we looked at all the patients available to us treated with 3D conformal radiotherapy. Some of the patients, the data wasn't available. And since 2012, when we installed the tomotherapy machine, we've treated 22 patients with tomotherapy. So a pretty even number of patients in each cohort, despite the difference in time period. All patients underwent pleurectomy decortication prior to radiotherapy, and all patients received the intended dose of 45 gray delivered at 1.8 gray per day. Follow-up times were different, obviously, for the reason specified before. The median follow time for the 3D conformal group was 19.4 months, with a large range, and the tomotherapy was just over 1 year. Looking at the patient demographics, age were relatively similar, with majority of patients being male. Most of the patients were right-sided in either cohort, and most of the patients had sufficient performance status to undergo radiotherapy. By tumor stage, slightly higher preponderance of the T3, T4 disease in the tomotherapy group, and similarly slightly higher node positivity rate in patients who were treated later on with tomotherapy. And in terms of histology, there were more patients with biphasic and sarcomatoid histology in the tomotherapy group. So the latter patients were deemed to be more aggressive in terms of their biology, and not surprising, those patients had more treatment with neoadjuvant chemotherapy prior to radiotherapy. So in just a comparison of the technique, the top is a 3D conformal technique where the green is supposed to depict the dose that was intended to cover the area, and there is underdosing of areas such as sort of the anterior chest wall and the diaphragm, compared to a tomotherapy where we're able to cover all those areas much more effectively. And just looking strictly at coverage, we compared the 3D conformal versus tomotherapy in terms of coverage of our tumor bed, our PTV, and basically the difference is about twofold. With tomotherapy, 91% of the intended surgical bed was covered to 45 gray, where only about 50% of the PTV was got the 45 gray using the 3D conformal technique. And breaking it down by different organs and the coverage, again, this bar depicts sort of tomotherapy covering the target much better than 3D conformal. In fact, the total lung for both sides got a little higher doses from tomotherapy because the way that the radiation delivered, not just from the ipsilateral side APPA, it's also spreading doses to the contralateral lung. The most differences in the contralateral low dose wash, because again, tomotherapy is delivering radiotherapy from the other side. The low dose is much higher in the contralateral lung in the tomotherapy arm, but the contralateral high dose is minimized to below that of 3D conformal treatments. Looking at sort of organs at risk, the mean hard dose, recent study from RTOG looking at lung cancer suggested that the hard dose was a predictor for mortality in patients that receive high-dose radiotherapy for locally advanced lung, something that we haven't looked at in the past. But from this study, we were able to show that for left-sided tumors, tomotherapy can significantly reduce the hard dose. And for esophagus, both right and left-sided tumors, the tomotherapy had a trend towards lower doses in terms of this normal organ. Now, looking at local control, breaking it down to the first 2 years, and then overall, we see that tomotherapy patients had significant reduction in local failure in the first 2 years. The reason we looked at the first 2 years was due to the median time of follow-up difference between the two cohorts. That said, majority of the 3D patients have failed within the first year. So I think looking at the first 2 years is a reasonable benchmark despite the difference in follow-up time. Distant control, again, because I think there were more biphasic and sarcomatoid histology, there was a trend toward a higher rate of distant relapse in the tomotherapy arm, but looking at the overall Kaplan-Meier curves, it was not statistically significant. Overall survival was no different looking at in either way by this analysis between tomotherapy and 3D conformal radiotherapy. And as Dr. Chen mentioned, the tomotherapy patients actually have very little toxicity, very few patients at grade 3 or higher toxicity. And basically, there was no difference in fatigue, pulmonary, skin, or esophageal toxicity between the two treatment modalities. So in summary, this is a challenging disease where there's high rates of local regional failure. I think we were able to show that using a better radiotherapy technique, we're able to reduce decrease local failure, and improvement in radiotherapy technique has led to a better outcome, which hasn't always been the case in terms of demonstrating translation of better coverage or better radiation technique to better outcome. But of course, survival is still the main endpoint, and systemic control is still the main issue. I'd like to thank my colleagues at UCLA. Dr. Kishan is a resident who did a lot of work on that comparison between 3D and tomotherapy, which last week we submitted for publication. Thank you. We'll move on to